Good morning, students. Today we'll continue the class on diabetes. The complications of diabetes. It can be short-term complications or long-term complications. Short-term complications are usually metabolic. So you have hypoglycemia, diabetic ketoacidosis, non-ketotic hyperosmolar diabetic coma, and lactic acidosis. All of these comes under the metabolic short-term complications of diabetes. Long-term complications are mainly due to microangiopathy, that is which is affecting the microvasculature, leading to angiopathy, retinopathy, nephropathy, and neuropathy, involving various systems. Angiopathy involving CVS, retinopathy involving the retina, that is a small blood vessels of retina, nephropathy, small blood vessels of kidney, neuropathy of the brain, CNS. The main pathogenesis of these complications can be discussed under three headings, that is non-enzymatic glycation, intracellular hyperglycemia, and disturbances in pyrrole pathways. This non-enzymatic glycosylation, it is basically glucose and protein binding the non-enzymatic bindings, leading to advanced glycogen end products called as AGE, advanced glycogen end products. Even though diabetes is a disease condition in the pancreas where there is decreased insulin production, it mainly affect, or you can even call diabetes as a disease of blood vessels. All the effects of diabetes is due to changes in the blood vessels. So diabetic angiopathy can be either macroangiopathy or microangiopathy. Macroangiopathy is the the changes seen in larger vessels like aorta. So here you can see atherosclerosis. Atherosclerosis, as you know, is accumulation of triglycerides or cholesterol and in the intima of large blood vessels. What does atherosclerosis do? Atherosclerosis narrows the blood vessels, leading to decreased blood supply to the organ and causing dysfunction, mainly infarction. So here there is atherosclerosis. This is coronary atherosclerosis. Coronary blood vessels are the vessels applying, are the blood vessels which give blood to the heart muscles. And so when there is coronary narrowing due to atherosclerosis, the blood supply to the heart decreases. And eventually, if the blood vessel lumen is completely obliterated, it will lead to myocardial infarction. Here you can see this is a coronary blood vessels. The lumen has narrowed so much because of atherosclerosis. And here there is a foci of calcification also. This is called as myocardial infarction, where the blood supply to the heart has decreased. The pathogenesis of microangiopathy on long-term hyperglycemia, that's a blood glucose level is high. There is glycosylation of basement membrane protein, as I said, leading to leaky blood vessels. Then and production of advanced glycation end products. AGE is advanced glycation end products. Sorbitol accumulation in the endothelial cells is occurring. Thick and leaky blood vessels occur. The lumen of the blood vessels narrow down, leading to ischemic organ damage. This is the basic pathogenesis. So here you can see how the glycogen end products accumulation and narrowing of blood vessels. This is the diabetic microangiopathy. Histopathologically, you can see the thickening of the blood vessels, micro blood vessels. Coming to nephropathy or diabetic nephropathy or kidney in diabetes will lead to diabetic nephropathy. These are the renal changes. It can occur. It can present as the usual urinary tract infection and pyelonephritis. Then you have renal papillary necrosis. The medulla, the tip of the papillae, get necrosed. Renal vascular disease, acute renal failure, fluid and electrolyte disorders. Of this renal vascular disease will, or otherwise the diabetic nephropathy, will go in little more detail. It is similar to the cumulative incidence of type 1 and type 2 diabetes mellitus. You can see the diabetic nephropathy in about 25% of diabetes patients after 20 years. Of this 25%, about 20 will require dialysis. And you should also know how often, in the sense, how many cases of diabetes you see in daily life. So diabetic nephropathy, in early stages, it is clinically silent. There is incipient nephropathy, or otherwise called as microalbuminuria. What is albuminuria? Loss of blood, loss of proteins, albumin in urine. And when you have microalbuminuria, it is more than 30 but less than 300 milligrams per day. And macroalbuminuria is more than 300 milligrams per day. And finally, leading to end-stage renal disease. In diabetic nephropathy, kidneys are the main targets. And you can see in the kidney, in the glomerulus, you will see there is diffuse glomerular sclerosis and nodular glomerular sclerosis. Before that, the lesions in the kidney can be described under glomerular lesions, renal vascular lesions, pyelonephritis, including the necrotizing papillitis, which I just described, and tubular lesions. So you have glomerular lesions, renal vascular lesions, pyelonephritis and tubular lesions. Of that, in glomerulus, you have diffuse glomerulosclerosis and nodular glomerulosclerosis, otherwise known as Kimmelstein-Wilson's lesion. This is a normal glomerulus where you can see there is the loops of capillaries within the glomerulus. In diffuse glomerular sclerosis, what you will see is there is thickening of glomerular capillary basement membrane. There is diffuse thickening of glomerular capillary basement membrane. What you see here is the diffuse thickening of glomerular basement membrane. Diffuse mesangial sclerosis. That is PAS positive mesangial matrix and mesangial cells will show pink color PAS positive material. That is what we see as diffuse mesangial sclerosing. The other one was diffuse thickening of basement membrane. Then there is diffuse mesangial sclerosis. And finally, you have the nodular glomerulosclerosis. What is it? It is otherwise known as Kimmelstein-Wilson's disease or lesion. Here you can see intercapillary glomerulosclerosis, and this is pathognomic, a pink hyaline material seen. They are usually situated in the periphery of the capillary lobes with patent or dilated lumen. These nodules can be PAS positive. And as the disease advances, the individual nodules increase in size and compress the surrounding nodules. You can see there are multiple of them here in this picture. You can see multiple Kimmelstein-Wilson's lesions. Pink hyaline material. Another special stain. Then you have the renal papillary necrosis. As you can see, the tips of the papillae is necrotic here. Also seen in the glomerular lesions are fibrin caps. They are prominent subendothelial accumulation of hyaline material. Subendothelial accumulation. You can see in this is Kimmelstein-Wilson's lesion. Just under this is Kimmelstein-Wilson's, but consider this as a small loop. Under the endothelium, if you have drops of fibrinous material, it is called as fibrin caps. Fibrin caps. And here, if you have drops under the basement membrane of the Bowman's capsule, you call it as capsular drops. Fibrin caps are prominent subendothelial accumulation of hyaline material, and capsular drops are round nodules adherent to the Bowman's capsule. Bowman's capsule, and are seen between the Bowman's capsule and parietal epithelium. Then vascular lesions are mainly hyaline atherosclerosis. Sorry, I have not reached the retinopathy yet. You have hyaline atherosclerosis and renal arteriosclerosis can occur. Then tubular lesions, you have Armani-Epstein's lesions, which is a proximal tubular epithelial cells with glycogen accumulation seen in an uncontrolled diabetes mellitus. The proximal convoluted tubule shows extensive deposits of vacuoles of glycogen. Now coming to this normal retina, here you can see cotton wool spots seen in retinopathy, diabetic retinopathy, cotton wool spots. Then you have microaneurysms and hemorrhages. There is hemorrhages and microaneurysms within the retina. These are another findings what you see in retinopathy. Then you have pre-retinal hemorrhage. In front of the retina, there is rupture and leading to hemorrhage formation. Then you have hard and soft exudates within the retina. These are all changes seen in retinopathy. Neovascularization. You can see new blood vessel formation or proliferative changes. That is called as neovascularization. And advanced plaques. This is the final stage. You can see the advanced plaque within the retina. Finally, the patient may have cataract because of increased osmolarity, that is sorbitol pathway. Coming to diabetic neuropathy.